Week 5, amazing. It's going by really quick. Remember, you do have that pediatric assessment project due. Week 8 is coming up quick. This is not a bad week to try to get it done or started. Remember that you need to tell me what is your subject? What is your diagnosis, pediatric diagnosis that you want to choose that you can elaborate on. As I always say, pick something that either you have, your child, your sister's child, your aunt, your uncle, friend, something that's more personal, and it will make it a better project for you instead of just busy work, okay? It is 3 parts. It's a very short paper, 250 words. It is that assessment form. Make sure you use it, fill it in as completely as you can. And the last part of it is NANDA, nursing diagnoses, that and Piaget and Erickson really helps you think. Those are really heavily looked on. So make sure they're there. And then there is a teaching. It could be teaching me how to give a medicine, could teach me how to be organized if I had, ADHD. It could be that simple. PowerPoint, 5 slides is more than enough. Just make sure you put references on it. And I know pictures tell 1,000 words. So sometimes using pictures helps instead of just writing, okay? If you hand it in early, I will check it, tell you what you can improve upon, let you resubmit so that you could get a better grade. It is 6% of your subjective grade, and it can affect your grades either way. So take advantage of it, get it in before it's due, and I'm pretty good on keeping on top of that, all right? But get your diagnosis approved from me, okay? I don't want to see all asthma, all ADHD, all one thing. Give me a variety. I want to learn something. Teach me something. Maybe it's a diagnosis. I like to learn too. So I want you to teach me. All right, let's hurry up and let's get this done. It is a heavy, heavy week as in information. So cardiac respiratory. So we know heart and lungs are connected. Absolutely. If you can't breathe unless you have the heart pumping medicine, blood through the lungs, and you can't have a heart if you don't have oxygen. So they're so interconnected. So we'll start out with the respiratory system, which is your lungs, your bronchus, all pharynx, ears, all of that is all connected, mouth down into your lungs, okay? So we have the upper, that's where you get the common colds, and lower, which is where we're gonna get like the pneumonias and stuff. Most of the time, when you get an upper respiratory, it is a virus, okay? COVID, it's a virus. RSV, it's a virus. Respiratory syncytial virus is a common cold for you and me, but on a young infant, it creates more problems. And it's because of the amount of secretions. And what does a baby do? They suck, swallow, and breathe, right? To eat. And if that nose, which they're obligatory nose breathers, if it's full of secretions, they can't breathe, so they're not going to eat well. And then you're going to see the retractions and respiratory distress. Other times you're going to see other stuff, but most of the time it is a virus. Now let's talk about something that happens with the infant. Infants are born, they got a great immune system. It's from mom. Every time mom catches a cold or has had a cold or bacteria or whatever, mom has these protective antibodies in her body. And when the baby's born, they're given to the baby. The mom gives them, but they start to wear off. So for the first 3 months, you're pretty well covered, these infants. This is why if you have an infant less than 3 months old who has an illness, sick, and a fever, we take it with high alert because this child shouldn't be sick with what mom has given them. So that is a high priority child to be seen and taken care of. And they will do all the way up to a spinal tap if they have to. Urine and blood and spinal tap and x-rays, all of that will be done. Now, as an infant gets a little older, moms good stuff wears off, it's gone. So that's why we give those immunizations. 2 months, 4 months, 6 months, right? Boom, boom, boom. What, 4 or 5 each time? It is a lot of immunizations we're given, but we want to protect that infant from those things that can be extremely serious and, could cause death to some of these kids. Now, as they get older, we know, what do kids do? Explore the world in their mouth. So they exchange germs all the time. So you have all of these viral things going on. The only thing upper respiratory that's really bacteria is ear infections, because we always treat those with antibiotics. And then as we get older, we'll get into more of the bacteria, usually the mycoplasmas, the strep, etc. And we know as a child gets these viruses, gets all these infections, the body's now building up all this good go away germs. You can't attack me because I now have immunity against it. So that's as we get older. Now everything's small in the upper mouth and nose. That's why you get a lot of ear infections. If you have a lot of mucus and the child can't expectorate it, blow it out the nose, which many can't, where does it go? Paths of least resistance. Where is that? Into the ears. That's why many children get a lot of ear infections as they're growing older. So what does a kid look like when they're sick? Upper respiratory. Well, every child is different. And this is why I love pediatrics so much. Not two kids are going to look the same. There's similarities, but not much. If there's an ear infection, it'll be pain. They'll be saying it hurts. And, I just went through that whole thing with the ears. In fact, last Thursday at the ENT, I had a tube put in this ear because of all the fluid, sinusitis, and I had an ear infection at my age, yes. So I had a tube put in the doctor's office and it hurt. So I can hear again. So I love it. When you have a kid who's sick, you're going to have a fever. How do you feel with a fever? I feel horrible, right? You just ache everywhere. You don't want to move your head. You're like, oh, well, kids feel the same. So what does a child do? Well, that's the kid who normally is bouncing around all over. You see him sitting in the corner, their head on a pillow, hugging, their stuffed animal or whatever, because they don't feel good. But another thing is they don't eat, right? When a kid is sick, they don't eat, they don't drink. They'll be anorexic, absolutely common. They might vomit, diarrhea, their tummy might hurt. They might have all of these things. But once we medicate that child for fever, that fever comes down, the kid's going to drink and maybe eat a little bit. It's the fluids which make a difference, because we know we lose a lot of fluid when we have a fever, right? We sweat it out. So we need to, those fluids are most important. And of course, your respiratory sounds, they're always junky, whether it's all in the upper oral pharynx or in the lungs. But kids are always, when they have upper respiratory, are really junky and you can hear it. So what is our goal? Well, we want them to breathe easier. We want them to rest. We want to make sure they're not spreading this all over the place. I mean, that's what we teach the kids, put the elbow up and cough into it, washing hands, etc. We've become really, really good with that, especially when COVID came around. I think a lot more so since we were before COVID. Our goal is get that fever down, because now we can eat and we can, what I said, drink and hydrate. And of course, kids always need hugs when they don't feel well. So as I said, otitis media, this is the escape. This is where it goes, into the ears. So how do we take care of it? Well, it is considered bacterial, and that's why the antibiotics, because your oral pharynx normally has staph in it, normally. But it gets up into the middle ear, and that's when it creates the problem. So what do? We place them on a course of antibiotics. We need to make sure that they take the whole course, not until they're feeling better, but the whole course. And if this is a kid, chronic. Now, I had 3 ear infections in the last 6 months, and then the fluid went there. That's why I had tubes. And children are actually the same there. So when they get all of these chronic ear infections, and that pressure is horrible and it hurts. So putting those tubes in, it lets it drain. So no more big bulging eardrums, and it feels better. So nursing care, make sure you medicate for pain is number one. And of course, fever, it's going to take care of it, and making sure they get rid of all the antibiotics. They take all of it. I also tell parents, have them sleep on 2 pillows, because when you lay down, the ears pull. And this is just one of my tricks, and it does help. If you lay them flat, the ears pull and it creates more problem. And then the kid's not going to sleep. And guess what? Mommy's not sleeping either. Now, I have a story about infectious mononucleosis. It's a virus, okay? It's a herpes Epstein-Barr type thing. You're tired and lethargic. They call it the kissing disease, right? So it's like, no big deal. Okay, I'm going to go into this. So it's Epstein-Barr, so you have fatigue. You have fever, and mostly the symptoms are the sore throat with its fatigue, like I feel like flu-like type things. But the other thing you see with this is you're going to see swollen lymph nodes in the neck, armpits, and you might even see that it's swollen enough, either the spleen or the liver gets swollen, and you might have a rash on it. So let me tell you what a scenario of mono might look like. The child, let's pick an 8-year-old little boy, because the end of the story has to do with an 8-year-old little boy. 8-year-old little boy, complaining of sore throat, fever, aches and pains, go to the doctor. They do, a strep throat check. They do a flu check, negative, negative, negative. Okay, it's viral. Send them home with taking ibuprofen, acetaminophen, plenty of fluids, and rest. 5 days later, they're still sick, or 3 days later. They bring them back into the doctor's office. They start a course of antibiotics. 5 days later, they're still sick. They go into the ER now, because now I'm really concerned. The doctor don't know what they're doing. Something's going on. So we hear this whole thing: sore throat, fever, lethargy, swollen glands. But let's do some blood tests. Well, we're going to do a CBC to make sure it's not bacterial. And we're going to do a mono spot test. And it checks to see if your child has mononucleosis. Well, comes back positive, mono spot test. So we're going to be doing teaching. Now, it is still Tylenol and Motrin and plenty of fluids and rest. Shatara, you have a question?
Yes, I was gonna mention that I recently found out that Epstein-Barr is linked to Burkitt lymphoma. So that's a virus that can potentially cause a cancer.
Well, look at that. I didn't know that. What type of lymphoma?
It's called Burkitt lymphoma. So
Oh,
with
wow.
Epstein-Barr, you know that it affects the lymph nodes, and it has the ability to immortalize B lymphocytes. So
Whoa,
it can alter it can alter the DNA, and is been known to be one of the viruses that can lead to cancer.
that is amazing. Thank you so much for letting me know that. All right, so let me tell you a little bit more about this monospot test being positive and teaching that we're going to do. So this little boy came into the ER, all these symptoms. We did a CBC, white count was normal, so it's not bacterial. Monospot test positive. So it again is Tylenol, Motrin, fluids, rest. So we told this father, we told this boy that he could not do any contact sports, that he needed to protect his abdomen, because that spleen, it gets like a big balloon and it can pop. It can rupture if the abdomen is hit, okay? They cannot go back to contact sports at all until they are cleared by their pediatrician. Well, this little boy came in onto me on a Saturday, and I just worked weekends. I did the Baylor shift at Nicholas. I was very lucky to have one of the last positions in it. Well, anyway, that next Saturday, he came back in, but he came back in on a helicopter. Trauma alert. This boy was on the back of a tricycle in Homestead, fell off, fell on his belly, By the time he got to us, his spleen had ruptured and he already died. I will never forget this little boy. The physician, really good physician he had, explained all of it. I went in and re-emphasized how you protect your belly. Don't do anything, at least for 3 weeks until you see the pediatrician. So the basic moral of the story, teaching, making sure that these parents and these children know the importance of protecting that belly, because it was a big balloon that was hit and it ruptured, and I'll never forget him. So no contact sports, protect that belly. Now you all heard of croup. Croup is that big bark, right? You can hear it from across the room. Oh, that kid is croup. It's barking, and it's inspiratory stridor, okay? There are different expiratory, inspiratory. This is, that epiglottis is little and the oropharyngeal airway is swollen. Getting air in is a little bit hard to hear as it gets worse. And then you hear this bark, this, it's like a seal, and it does sound like that. If you do not take care of croup, it could go and get into the epiglottitis, and we're going to go into what that means. But again, all it is a virus, and we need something for the inflammation, a steroid, to take care of it. Now, another one of those upper airways, tracheobronchitis, which is all upper airway again, is an inflammation. Now, this is the one that is annoying. This is the one that keeps you awake all night long, dry, hacking cough, and it's worse at night. This is the one where you can't sleep. This is the one where they say it's due to a virus, but they always put these children, even adults, on a Z-Pack, and they'll give you one of those Medrol dose packs of steroids to try to help you, and they'll give you some sort of cough medicine to try to help you so that you can sleep. That's the big thing. So bronchitis, dry, hacking cough at night. Then that laryngotracheal bronchitis again. This is your flu. This could also be, it's all upper, could be all that mucus, could be your RSV, okay? So these things, again, they're viruses. So usually your laryngotracheal bronchitis is you have an upper respiratory, again, inspiratory. You can, because it's hard to breathe in, have those substernal retractions, the barking, like I said. And if, again, croup, this is basically what it is. If we allow this to continue and we don't get treatment for it, it's going to lead to more distress, hypoxia, and it could go into respiratory distress or acute epiglottitis. Well, what is an epiglottis? That's that little leaf-like structure that covers the trachea when you swallow food. So food doesn't go into your lungs. Well, that gets swollen over the trachea. So how does air get into there? It's covered. It's very little piece of it, maybe, air can go in. So you have no air going in. They can't swallow. They don't cough with this one. You just see these kids bent over. They are drooling. They can't swallow. And if they talk, it's going to be this muffled sort of sound. Now, this is very dangerous, and it will lead to death if we don't do something to open that airway, okay? Again, air don't go in. This is, again, an inspiratory, just like croup. So how do we take care of it? Well, of course, we're going to do anything to get that airway open. And if you saw here, it is make sure, especially, epiglottitis, and you can't see it in the mouth, so you don't even look there. Don't disturb it. But make sure that you have an endotracheal tube for intubation or a trach tray at bedside. Because sometimes, even with getting the epinephrine in, the steroids in, your O2 type of nebulized medicine's albuterol. Nothing is open. They're going to have to do something to open the airway. And it is very scary. These kids get very anxious. These kids, if they want to sit on mom's lap and they don't want to move, leave them alone, leave them where they are, keep them as calm as they can. Because this child will, if they can't breathe, they're not getting oxygen. So can you imagine how air hungry that would be on these children? Now, once we get a little airway open, let's say we don't need to do intubation, we don't need to do a trach, we're going to put an IV in, give them fluid there, and then we give them like little moist type of oxygen. There's a mask that puts moisture in there, different than just a regular simple mask. And that keeps the moisture and will keep it open. So epiglottitis, medical emergency, and it's the drooling, it's the big thing. All right, RSV is also known as bronchiolitis. As I said, this is infants that it really does affect. And the infants we are more concerned about is those with congenital issues. Let's say a kid is born with congenital heart defects, already has a trouble with oxygenation. And now we put mucus in the nose, little fever, they can't eat, and now they're becoming more and more of respiratory distress, and they already have a cardiac condition. So that kid is sick. So we do have prevention. We do have an immunization, and it is called Synagist or palivizumab. It's a biologic. Now, it's only the first year of life, and it's usually winter to spring, once a month. And we give this, and it helps prevent the RSV. Nursing care, if you get a kid coming in with RSV, is to suction before they eat and monitor O2 saturations and make sure they keep hydrated. If they can't eat, they're going to get an IV. Now, tonsillectomies. I mean, many kids, what's the two surgeries they have? Most common, tubes, tonsils, adenoidectomy, right? Those are the ones that happen. Now, how do we take care of that tonsillectomy, and what instructions are you going to give those parents and the older children? Well, you're not going to have them on highly seasoned foods. Anything spicy, it's going to burn. Just like you're not going to give citrus, it's going to burn, right? Do not gargle, no vigorous toothbrush. Now, let me explain what they do in a tonsillectomy. They cut off and burn and cauterize 2 areas in the back of the throat. And what's left is 2 scabs. Those scabs can fall off. And guess what happens? When it falls off, they can bleed out and hemorrhage. So we don't want to do anything to disturb that, okay? So no gargling, no vigorous toothbrushing, no coughing, no clearing throat. Keep everything out of the mouth, like a straw. These kids like the straws, right? You're just going to give Tylenol for pain. It's all they really need for it. And then if the kid wants an ice bag for the neck, many kids don't like it, but it does work. And they should be relaxed for a couple of days, okay? And the one thing, older kids, there's a lot of pressure because the ears are connected. Have them chew gum. It's like popping their ears, like going underneath water deep. Your ears get clogged, but you don't want to blow your nose and pop your ears. Chewing gum actually relieves that thing. If you are seeing that your mouth stinks, and you will know if there's an infection, it stinks. Low-grade fevers, get into the doctor. If they're having those persistent earaches, fevers, etc., they need to get in to be seen. And of course, they can go back to normal activity within 1 to 2 weeks. I actually saw a little girl 1 week post-op, had just come from the ENT, and on the way out to go home, she vomited big clots of blood. Came into the ER, I was in triage, and she was filling buckets of blood and big liver clots. I picked her up, carried her into the triage room, started an IV. She was going into hemovolemic shock from loss of blood. That little, she was like 7, I want to say, she got a liter of fluid. That's how much blood that was coming out. And they had to go to OR and recauterize her throat. So even tonsils are serious, right? Pneumonia is either you breathe something in or there's a collection of mucus in your lungs somewhere. It could be bacterial, viral, mycoplasma, pneumococcal, and we know we do have the pneumococcal vaccine right now, which really has decreased the amount of that. Pertussis. Pertussis there is a vaccine for, but some children don't get immunized. And there was an outbreak a couple of years ago. And the thing is, it's highly, highly, highly contagious, and it's in the air. Okay, so these children going into a doctor's office or into an ER, they're breathing, they're spreading pertussis around. And some children, maybe they haven't gotten, immunized, or even sometimes immunized children can get it. So these children must be placed immediately into a reverse airflow room, which means the room doesn't let the air go into the public. Okay, it's like separate them in another house. It's that sort of concept. Okay, and yes, the vaccines are there, and they should be taking them because it is preventable. Now, what do kids do? Everything in their mouth, right? Explore the world through their mouth. You know that picture? That is a quarter right there in the esophagus. And children, this is not uncommon. And you would think it would be good if they had a dime or a penny. They always choose the quarter, the big one. And they come in and it hurts. And we need to get it out. So, of course, always you're watching for upper respiratory, making sure they're breathing, etc. But go do the x-ray, take it. And do you know how they get that quarter out of there? Years ago, they went to the OR, did a bronchoscopy and clips and pulled it out. But you know what they do today? You'll have the surgeon come. This child will sit on their lap. They take a Foley catheter with a balloon on the end, put it down below where the quarter is, blow up the balloon, have the kid sit forward, and they pull it out. The kid vomits, and the quarter comes out with it. You know what I tell the kid? So they're not going to be afraid. I said, once that quarter comes out, it's going to fall on the floor. And if I get it first, it's mine. So these kids, it comes out, it's on the floor, and they're on the floor trying to get it. They never remember that that was going to hurt. They're more focused on that quarter. That's a distraction device. And I've used that more than once, and it works well. Years ago, Johnson & Johnson baby powder on everything in the air. And we found out there was a lot of problems with powder. That's one type of aspiration pneumonia. The other one is that kid with reflux, with food going up into the lungs. I'm making sure that we burp them right. They're positioned sitting up after their foods, or even thickening the food with some rice cereal. Even though rice cereal has no nutritional value, you're going to see it come out in the stool, but it thickens that formula enough that they can keep it down, and they're not going to aspirate. Cystic fibrosis is inherited. It's autoimmune, and it's two components. It has to do with the lungs full of this really thick, cloggy mucus. It also has to do with digesting food in the small bowel. And fat is not absorbed, and this requires medicine to be given, pancreatase, immediately before they eat food or snacks, and it helps dissolve it. Now, if you didn't know a kid had cystic fibrosis, or maybe, this child hadn't been diagnosed yet, well, the way you diagnose it is through a sweat test. And the sweat test is just measuring the amount of salt on their skin. Now, I've said this before, a kid who's going to possibility of cystic fibrosis, if you're wondering if they have it, I'll just tell the parents, lick them. Does it taste like salt? They lose salt like crazy through their skin. So if you lick them, you're going to taste salt. So this would be a child that you would never, ever have them on low sodium. They need that extra salt. Because their lungs are filled up, you need aggressive chest physiotherapy. Because there's all that mucus, it's like a petri dish waiting for bacteria to grow. Chronic infections, you'll hear them wheezing, they're going to be short of breath. And because of their problem with nutrition and they're losing fat, they're going to have greasy, foul smelling stools, going to have abdominal distension. And because they're not absorbing all the nutrients, they're going to grow slow because they're not getting the calories that they need. So as I said, you're going to do that sweat test, and then you're going to do all this stuff for their lungs. A lot of times they even do antibiotics for, like, instead of albuterol, they'll put antibiotics in their aerosols, and it gets down in there. And you're going to have one of your questions on your NCLEX questions about the pancreatic medicines, but these are the key things. Many times they come in some sort of capsule, and not every kid can swallow a capsule. So you open it up and put it on the food, or it might be powder. You open it up and put it on their food. Make sure that one, we rinse our mouth out afterwards because it can hurt the teeth, okay? And the one thing, if they're in those enteric coated things, never enteric medicine do you crush it. That must be taken whole. If they can't, another thing must be taken. And as children grow, they're going to need a bigger dose. And I think with all medicines, just like anti-seizure medications, it's another one. Make sure that we increase the dosages as they're getting bigger, or they're not going to be getting all the nutrition they need. Now, what's peculiar to cystic fibrosis is men are not born boys without a vas deferens, which you need that in order to get the sperm so that you can impregnate the woman, okay? Women can get pregnant, but they're gonna have a high risk delivery, okay? They need to be closed. Now, men, if they want to have a child, they do a bilateral lung transplant, and 1 year after, they can get their woman pregnant to have a baby. So men are the ones that have the issue with cystic fibrosis and pregnancy. Now, acute respiratory distress syndrome is some sort of thing that can happen where the lungs have a moment where they didn't get oxygen. It could be due to overwhelming infection, sepsis, could be trauma, could be a drug overdose. And then the other one is near drownings. You know, near drownings, you have up to 72 hours that symptoms can arise. ARDS is an extremely ill child. It's due to the hypoxic moment or time that they didn't get oxygen. As you can see, mortality rates is very high. These children, I mean, this is an ECMO machine on a younger child where they breathe for it. It does not mean the kid's going to make it. These kids are ill. Usually they're one nurse and one patient because they're that sick. Now, remember CPR, it's a hard time for the parents, mostly, right? Now, parents want to stay there at all times. Many times of what's going on, they can't stand next to their kid. Make sure that we have somebody there, you know, talking to the parents, letting them know what's going on. You know, I've had brand new infants, newborns come in, you know, and the mother gets there the next day and the kid codes and they were in the room, and you have to kick them out because of the amount of people that have to attend to this tiny little infant. And many a times I'd be standing there holding the mother's arm, hugging her, letting her sit down, giving her tissues to comfort them. So updates are important. Asthma, everybody knows what asthma is. It's when you can't breathe and you have that little puffer, right? And it's due to some sort of over responsiveness to some antigen. It could be cats, dogs, it could be grass, it could be cockroaches are a big one, believe it or not. allergic to it. And we know that we need to find out what the cause is through allergy testing, and we need to treat it and to avoid them, right? We need to see how the lungs are working through pulmonary function tests, as I said, doing the skin testings. But the one thing with kids, we need to let them be normal. Now, if they're allergic to grass, you're not going to have them outside playing soccer or baseball, but they can do other sports that are not in the grass, right? Until we get them to the point where we have those allergens under control. And through allergy testing and giving them, shots to get them desensitized, we can. Always remember, kids with asthma need to know, especially if they're older, their little rescue, their albuterol, little inhalers, make sure that they know how to take it. And younger kids, you see that little thing to your left on the bottom? Those are spacers. How many people can push a button and inhale at the same time? There are adults who can't. So it's in small, medium, and large sizes. So infants, it's actually better than a 15-minute aerosol, right? Put the little mask on, squirt it once, twice, whatever the dose is. They breathe in a couple times. Infants who are crying, guess what? They're taking deep breaths, so they're getting the medicine really well. We also have them on different course. In pharmacology, we learn you're going to have your rescue, and then you're going to have your long-term control things, which is morning and night. In children, the one that's used a lot is Pulmicort, and it has a little bit of steroid in it. And that's the prevention of your bronchus not to have an attack. Okay, so it decreases those spasms. Albuterol is rescue, so try to open it up. In case of a moment where these children are going through an asthma attack, steroids, anti-inflammatories do help. And we know that children also are getting something called Singulair, which is like a Claritin, but a Claritin for asthma, and it's given at nighttime. And I know the last time I looked it up, they're giving it from 2 years up now. They didn't usually give it to the young kids, but now they are. All right, let's go into the heart now. Now, if you're not understanding, you need to stop me. So let me explain it to you, okay? So there are 2 types of heart defects. You're born with it or you catch it along the way due to whatever, simply. Now, you need to understand the way blood flows through the heart, okay? You need to know the names of the valves, and you need to know what side of the heart they're on. So this is anatomy and physiology. And with that, think about the heart and the blood vessels as a hose. What happens when you kink the hose? The blood or the water goes backwards, right? Think about that as we're discussing this. I'm going to give you an example right now. So we know it goes in through the right side. The blood comes back to the heart, through the right atrium, through the tricuspid valve, into the right ventricle. It goes up into the pulmonary system through the pulmonary artery, and it comes back down into the left atrium, all oxygenated, ready to go. Goes through the mitral valve, into the left ventricle, then it goes to the body through the aorta, through the aortic arch to the body, and goes everywhere. Now, what happens if there's a kink in the hose right after those 3 vessels that are on the aortic arch? There's a kink. What's going to happen? Blood can't go down low. It doesn't have a big opening. There's a little opening, so a little blood flowing. Well, how would we know that? Well, you wouldn't necessarily hear anything at birth because baby's brand new. But what symptoms assessment? Well, if the blood can't flow downwards, your popliteal and dorsalis pedis pulses, the feet, are going to be decreased or absent because blood's not getting there. Capillary refill is going to be almost nothing. Okay, that's your first hint. Once you see blood's not going down there, you're going to take a 4-extremity blood pressure. The blood pressure on the low side, now blood's not going, blood pressures are lower. Now, because it's going upwards, the upper blood pressures on the arms are going to be higher, usually at least 20 millimeters of mercury higher, okay? Also, if you see those 3 things going upwards, that's going to the head. Many children are older when we find this. And because of the extra flow going to the head, you're going to see nosebleeds and headaches. Makes sense, right? Because extra flow, it hurts. So think about coarctation of aorta. It's a kink in the aorta, and that is the signs and symptoms. All right, let's keep going. So cardiovascular dysfunction. Now, many times you don't see a child what's going on. Like that thing I just said, I had a little 3-month-old girl transported from the West Coast, had been in and out of ERs, doctors, was getting more and more short of breath. Nobody knew what was going on. So finally they said, oh, maybe it's cardiac. They were thinking maybe, they didn't know, sent her to Nicholas Children's Cardiac ICU. I worked there for 10 years also. Symptoms. Well, if the kid is having all of this blood not going downwards, some is going up, but where is the rest going? It goes back to the left ventricle, back to the left atrium, and it's filling the lungs up with fluid. So now you're in congestive heart failure. So you see poor feeding, tachypnea, not gaining weight because they can't breathe, they're full of fluid. They have no tolerance for anything. They're not getting nutrition. You have developmental delays. You might have a history or may not, but the whole thing is they're in congestive failure at this point. They can't breathe and they're struggling. So poor weight gain is why. Inadequate oxygen perfusion leading to activity intolerance, resulting in diminished energy to breastfeed. Now that makes sense, doesn't it? So when you look at a kid, what do you see? Well, you want to see what their weight is, you know, what their color is. We're going to look at the chest. You can sometimes feel the chest of a newborn with a murmur, and you can feel it buzzing. You really can, because it's like bzz, bzz, or or just that would be a VSD. Really loud things, you're going to hear it. And then as they get older, you might see the clubbing of fingers. And I have an example for that as we get older. You always look at the chest, you palpate it, you listen to it, and you look for pulses. Again, peripheral pulses are important. Any suspected cardiac kid, 4-extremity blood pressures are important. And of course, we're going to look at that heart rate. Is the rhythm, is it adequate? And of course, the sounds. Are there murmurs? Are there extra sounds, etc.? All of those make a difference. Now, once you see anything abnormal, the next thing that's going to happen is a cardiac catheterization, guaranteed. So we've done an EKG, that's normal. We're going to do that echo now, see what's going on, and we're already scheduled for that cardiac catheterization. And a cardiac catheterization really narrows down where is the defect and what do we need to do for this child. And sometimes we do what we call electrophysiology studies. Those are for that child, it's interventional. And just think about, even in adults, it happens where all of a sudden the heart beats really fast. And then it goes back to normal. So your heart rate's up and down. There's somewhere in that right atrium that just wants to take over the pacemaker of the heart. So what they do is they find where that little place is and they zap it with, you know, a radar gun, you know, and they get rid of it and it stops beating like that. So that's an EP study, is another name. So we need to know how to take care of a child. Now, preoperatively, infants are usually the one that we're talking about here, even older kids, but many of the congenital heart defects, they're born, right? They're born with it, newborns. So they're going to eat up to about 2 hours before they go for procedure. That's about all they do. Now, post procedure, what they do is they put 2 big catheters in the right femoral artery and right femoral vein. And they thread it up into the heart and they shoot dye and they look at what's going on. When they're done, they take out these big catheters and they hold pressure on it. Now, these are huge vessels and huge catheters comparatively for a child. They can bleed really easily. So you get a kid back from cardiac catheterization. They've had to be taken, put into their bed, they're being moved, they've been jostled down the hallway, brought back to your room, and that could have disrupted the clot of that bleeding. So these kids can bleed all over the place, all right? So first thing you're gonna do is check that dressing. If they're older, they'll have a sandbag on it. And if they're younger, they just have a big, nice, tight pressure dressing. Now, what happens if it's bleeding? You take 2 fingers and you put it above, closer to the heart, about, if this where it's bleeding, right above. So right above, and you push it and you call for help. Now, the treatment is just to hold it, but if it's a lot of blood, they may need blood. So of course you're going to need a physician in to evaluate it. You're also going to be checking the pulses because they're going to be a little bit decreased, just to document so everybody knows what it is. You do vitals. They're either going to drink PO or they're going to drink, with IV. Both are okay. Children are always very susceptible to blood glucoses up and down. We always check them. Even stress can cause low or high glucoses, so we do check it. These children are in bed for the first day, 24 hours bed rest. You don't want to disrupt that clot, and that leg must stay straight, okay? They can't be up walking around. Now, congenital heart defects, we don't think, that there's a lot of them, but you'd be really surprised how many congenital heart defects there are. It is the major cause of death in the first year of life after prematurity. I mean, that's huge. Now, the most common is a VSD, and the most common baby that will have it are the ones with the trisomy 21, 13, 18. And you're like, well, what are the numbers in trisomy? 21 is the one we think about, Downs. 18, 15, 13, 11, and 9. The smaller the number, the more complications. That child with trisomy 9 is a Downs, but a 9. I met one child, was blind, could not breathe without a ventilator, had half a heart, had 2 fingers for the hands, each one, and 2 fingers for the toes. So really not formed really well. The child lived for 1 year like that and had heart surgeries and everything. Okay, congenital heart defects are 2 things. Now, just that VSD, ventricular septal defect, a hole between the ventricles, between the 2 right and left ventricle. Simple as that. Or, you have the atrial septal defect, which is just, the septum. There's a hole between the right and left atrium. Now, they're acyanotic. That means the blood is going to the lungs, it's going back to the heart and going to the body. There is some recirculation. Yes, some of the blood goes back into the lungs again, but there's oxygen. And then there's other ones that we call cyanotic, and we'll get into those. Always remember, blood flows from high flow to low flow. Just like the oral pharynx, we have all that mucus. All the mucus is here. It goes up into the ears. Same concept, okay? So let's look at some defects. Now, ASD, VSD, if we have a hole between the septums, The blood's going to come from the left side and go back to the right side. Think about this. The blood goes from the left side to the body, and it just gets back to the right side and drips in. So you have very low flow there. So the left side, you have all this blood coming from the lungs, okay? So it's high flow. So it's going to go from the left side over to the right side, back in the lungs. And that's okay. It's just, extra oxygenation. Now, a PDA we're going to talk about a little bit later. It's something that is a life valve. It's one of those things that was made to save lives of children with really severe defects. Now, you can have obstructions. I've already mentioned coarctation of the aorta. And you can always have a valve that's just not open enough. Usually, you see the aortic or the pulmonic valves. That means blood is not getting to the lungs well, or it's not getting to the body. That's what that means. Decreased pulmonary blood flow. Remember, we're talking about oxygenation, decreased flow. The one diagnosis you will see, exams, HESI, NCLEX, and the one they like to use for cyanotic heart defect is tetralogy of Fallot. And tetralogy of Fallot is when all of a sudden the pulmonary valve says no blood's going to the lungs, and you go from O2 saturations of 100, and I've seen them go to 10 within a minute. I mean, that's how severe that thing is, and we're going to go into that. And then we have some mixed stuff. Tricuspid atresia. Well, let me give you two definitions. Stenosis is a narrowing. Atresia, A is without, no opening. What happens if you have no opening between the right atrium and the right ventricle, which is tricuspid atresia? That's where that tricuspid valve should be. How are we getting oxygenation? Right? Nothing's going to the lungs. Well, that's the PDA, fetal circulation, that keeps open. The other thing is transposition of the great arteries. The aorta and the pulmonary artery are switched. So you have blood going to the lungs, blood going to the body, and they're not mixing. How do we get them mixing? Patent ductus arteriosus. Okay. And then the worst of all conditions is when the left ventricle does not form well. There's no pumper, there's no engine on the heart, and that's called a hypoplastic left heart syndrome. And that is a 3-stage surgery, and one of the ones that require a lot of care. All right, patent ductus arteriosus, very important. This is there for fetal circulation. It connects the lungs to the body circulation. It is an opening, a tube between the pulmonary artery to the aorta. So now the lungs can feed the aorta or the body oxygen, okay? Usually after birth, mom stops producing something called this hormone called prostaglandins, and this thing closes, okay? Now, many of the times, and I've seen it mostly in premature infants, it doesn't close. So you have all of this extra blood flow going from the body to the lungs and the lungs to the body, and it's, just washing out the blood, and it needs to be closed. Now, how would you know this PDA is open unless you did an echocardiogram, right? Well, there are two things that you see. Well, number one, if you listen to the heart, it sounds like a washer machine. You can hear the swooshing of it going away. But the other thing is, many of these children suspected cardiac always have arterial lines, and it's called an umbilical artery catheter, okay? UAC, umbilical artery catheter. And it measures the blood pressure all the time. And look what it has, a wide pulse pressure. Now, a normal blood pressure on a newborn infant, that neonate, is 60/40. That's a beautiful blood pressure. Well, because of this extra opening, this PDA ducting, the blood pressure is like 60/18 wide pulse pressure. So you hear that loud murmur, you see that wide pulse pressure going on, you know there's still a PDA. Now, one of the things is how do we keep it open when we need it, right? For the coarctation of the aorta or the transposition, or how do we get it gone? We don't need it here anymore. Well, as I said, PDAs are kept open by mom delivering a hormone called prostaglandins to this vessel, and it keeps it open. And at birth, mom stuff goes away, but we do have a synthetic prostaglandins, and it is given in a slow, continuous infusion. So now we kept that tube open. Now we have oxygenation going on, and it also maintains the cardiac output. Okay? So prostaglandins, important, maintains cardiac output and oxygen saturation levels. Now, let's say we don't need it, like it's still there, I want it gone. Well, you don't need to do surgery. There is a medical way to close it, and is with something called indomethacin. And it's actually an,
Tocolytic.
excuse me?
A tocolytic. A
Yes,
tocolytic.
yes. Now, indomethacin is an NSAID. It's like ibuprofen. It's an old-fashioned one, but they have it IV. And when I first heard this, I'm like, what? You use indomethacin for back pain? I don't get it. And then, of course, I read into it. But what it does, it stops prostaglandins from being formed, because apparently the baby's doing it somehow. And what you do is you give 3 doses, usually like 12 hours apart. And how do you know it's working without, again, an echo? Well, the murmur goes away. And guess what? That blood pressure goes back to normal. So you can actually watch it as you're giving this medicine. Those 2 medicines you need to know. Prostaglandin, keep it open. Indomethacin, close it. So increased blood flow, ASD, VSD, PDA, we know that. And there's some pictures here that I've given you, but I've really gone over a lot of them. The tetralogy of Fallot, that's when, again, something goes over that pulmonary artery. And guess what? We don't have oxygen going on. And we'll go into that, the mixed, I've gone that. Let's go now into, I don't want you to go crazy looking at blood flows. It'll just drive you nuts right now. Let's ingest what we know. Now, as I said, like coarctation of aorta can cause something called congestive heart failure. Now, what do you see? Now, this is a newborn going into congestive heart failure, and it's usually a result of structural abnormalities like that coarctation, right? Now, because that blood is going back into that left ventricle, it's stretching that left ventricle out as it goes and pushes the blood back up into the lungs, okay? So we need to get this fixed as soon as we can. That little girl, that 3-month-old girl from the West Coast, was 3 months old with a coarctation of the aorta. Her left ventricle was really stretched, and it really caused issues postoperatively that we had to, continue treating. What do you see with congestive heart failure? The lungs are full. I mean, an X-ray, you're going to see them full of fluid. Now, what is our goal? Well, we want to get rid of that fluid, right? We want to have that child breathe easier. So how do we know if a child is losing fluid? Yes, we're going to be given furosemide. Probably give some digoxin to have that heart slower and squeeze that heart better to get that blood going and get rid of that fluid, okay? And that's going to improve your cardiac function. But how do we know it's working? Daily weights, strict I&O. If you're losing weight, you're losing fluid, right? So weights are so important on this. So we want to get rid of that fluid. We want to make that heart work better. And we want that child to be oxygenated the way he should. Now, as I said, we're going to give digoxin. We know how to give it to adults, right? Is there anything different with children? No, but you have to know heart rates that are normal for the age child you're giving it to. That's the trick there. So if it's a newborn, if a heart rate is below, and they usually say 100, and that's pretty low, you're going to hold it and call the doctor. And you're going to count apical for 1 minute. Still the same thing with IV digoxin. You're going to worry about potassium. You need an adequate one. And if you have a frequent digoxin level there, if you have one, what is it? Is it normal? Is it within limits? And the one thing with infants, and we need to teach our parents, is if this kid is vomiting at home for really no reason, what is one of the side effects of digoxin? It's vomiting. So we need to have them call the doctor and make sure that they get a digoxin level. Hold the dig and call the doctor, okay? Very important. It might just be one little vomit that comes up. So again, we're giving digoxin, we're giving the furosemide, we're weighing them, and again, trying to keep nutrition. Some of these kids in congestive failure will put in a feeding tube just to get them their food because they cannot suck, swallow, and breathe. So hypoxemia is a condition where you don't have enough oxygen in your body. Now, I mentioned that hypoplastic left heart syndrome, right? The normal O2 saturation at birth is 65 to 75, maybe 85 if you're lucky. So what does the body think? The body says, oh, it's not good enough. How can I improve this in order to get more oxygen around to the body? Well, it starts producing red blood cells. It's trying to help. But what happens is it causes polycythemia, which is the production of red blood cells. And you're going to see hemoglobins and hematocrits. I've seen them 18 and 54, which is, you should have what, 12 and 36 is fine. So really dark red, thick blood because the body's trying to compensate for that low oxygen. Of course, you're going to see hypoxia and cyanosis. And if it's a hypoplastic heart with these lower O2 sats, as they get older, you're going to see clubbing, which looks like that hand there. So again, as I'm telling you all the way through, we're teaching. I have to tell you, cardiac parents are probably some of the nicest ones you'll ever meet. And they really want to know what's going on. So they really need to be taught how to manage their child, especially after they go home. Let them know what's going to happen, what to expect for, and your kid is going to be a better kid for that. As I said, cardiac cath, I really went over this, but this is a reiteration on it to look at it even more closely. Bacterial endocarditis. This is an infection of the endocardium. Again, this is one that's going to need prophylaxis before any procedure, tooth, dental, anything. Now, in pediatrics, there's two conditions caused by strep throat that are serious and dangerous. In the cardiac chapter, it's called rheumatic fever, which can turn into rheumatic heart. What happens is you get a kid who had a sore throat and they said it was viral. They didn't do anything. And after a while, it went away, no treatment. Or a parent was given, they did the swab, they found the strep, they were given antibiotics and they didn't finish it, or they needed another course and they didn't go back and check it. So what do you see with rheumatic fever? Well, you see a kid with a sore throat, fever, and then all of a sudden you're going to see these joint swelling, you're going to see a rash, and then you're going to be seeing this chorea, which is shaky movements that are uncontrollable. And it's usually when they get there where they get into the treatment. Now, all of this can be turned around with a long-term antibiotic. The heart, it affects the mitral valve. And if it's gotten to the point of affecting the mitral valve, it is permanent. That means the valve is going to need repair or it's going to be needing to be replaced. So rheumatic fever caused by strep throat could be 3-4 weeks ago, and they usually come in with those symptoms. Everything can be reversed except for that heart valve. Children can get hypercholesterolemia. We're told that we need to give kids high fat to the age of 2 because they need it for growth, development, central nervous system. But there are some familiar history of it, so it needs to be watched and looked at. And we're looking at that a lot more today. We're doing blood pressures on younger kids than we ever did before also. Children's heart rate can be fast, slow, or irregular, just like adults, and they're treated. Actually, the medicines are just like adults, but they are in pediatric doses. Something called pulmonary artery hypertension. Sometimes blood flow goes to the lungs too quick, and the lungs say, oh, they don't like it, and they just tighten up and don't let blood flow through it, and it becomes more permanent. So it's called pulmonary hypertension. Many of these children are placed on medications. Actually, Viagra has been used for pulmonary artery hypertension in children, infants, and it's worked. We had a kid come back from Boston and was on Viagra, the first time I had seen that. So if you can't breathe, not getting enough oxygen, those vessels are tight, you're going to see dyspnea with exercise, chest pain, and syncope, all because they're not breathing right. The heart can get enlarged and swollen and the muscles floppy. Many times it's due to a viral infection, but it could be familiar, could be due to some sort of deficiency, metabolic or collagen disease. And these children every now and then are going to be needing to do what we call a tune-up, be placed on medications, give the heart a rest, and IV medications, not just the normal ones they take, orally. And sometimes that heart gets so bad, especially with those hypoplastic hearts, that they need a transplant. And the biggest thing we worry about is rejection. So I've seen many hypoplasts go for it, and I've seen some really good cases, and I've seen some not as good. Post-surgery, children have chest tubes in, and it could be 1, 2, 3, 4, 5. Doesn't, it depends on what they need. And one of the things is getting them pulled out. Now, I worked in adult ICU, cardiac ICU, and I've worked in children's ICU. So I've asked adults, how does it feel when they pull that tube out? And they say it's an intense, burning, horrible pain, but it's only there for like 30 seconds a minute, and then it goes away. But it puts them in tears. So what does that tell you about children who need chest tubes taken out that are old enough to understand? Well, never lie. Always tell them it's going to hurt a little, but it will go away pretty quick, and you'll give them some medicine to help them with the pain. Okay? Always on their level, and take the vital signs before, give the pain medicine, and you take the vital signs after to make sure that the vital signs are good after that pain medicine. As I said, we are taking blood pressures earlier than ever. All of a sudden, we're taking blood pressures for kids at 2 and 3 years old because we're finding hypertension in young kids. And we know untreated hypertension can cause kidney disease and failure, right? And then Kawasaki syndrome. This is a virus. It is what we call an acute systemic vascularitis. We have no clue why it happens. And it's that vascularitis or inflation, infection, inflammation of the vasculature or vessels, right? The ones we're worried about is the coronary arteries. They could get ballooning or aneurysms and they could burst. So these are the symptoms. Now, the one that was the most prevalent that I've seen, this little 3-year-old boy's eyes were as red, like glow in the dark. I have never seen eyes that red ever again. You're going to see the red lips, strawberry tongue. You might see swollen glands. Hands and palms of the feet are going to have peeling on them. Okay. And usually these children have been sick for 7 to 10 days and they're in and out of hospital, doctors, etc., until somebody finally figures it out. And it's usually by symptoms that they figure it out. So what do we treat them with? Well, I told you about that possible aneurysm. So an echocardiogram as soon as they can, right? To make sure their cardiac status is okay. But they give intravenous
Aspirin?
gamma globins or IVIG. And yes, aspirin, high dose aspirin. This is the only time do we give aspirin to children. And why do we give aspirin?
The coronary artery effects, like because it damages the arteries. You're trying to prevent like clots, like an aneurysm.
It's clots. Yes, it's to thin the blood for the clots. So there's clots, they don't get pulmonary embolus. And again, make the blood flow easily so that aneurysm isn't stressed. Very good. Absolutely. Shock, any age kid can get it. You know, most of the time when you talk about shock and children and infants, it's septic shock. It has to do with overwhelming sepsis. So, all right, here we have a question. Think about it for a second. Surgical closure of the patent ductus arteriosus would do what? The connection between the pulmonary artery and the aorta. What will it do? Blood flows out of that left atrium up into the aorta and through the pulmonary PDA goes back to the lungs. It prevents the return of oxygenated blood, right? So you're not overwhelming those lungs. So as I told you, there's a lot of stuff here. It's pretty intense. I'm going to try to get you through this cahoots. It is a lot of questions. I know if you need to leave, you need to leave. But I'm going to try to squeeze it in for you. Very important one, a lot of information on it. But I didn't want to underwhelm the lecture because of it is intense. And I wanted to make sure I explained it enough for you to get it. Nobody wants to join tonight, huh? You want to sneak out the backside? Is that what you're doing? It's okay. I get it. I understand. 10 o'clock at night almost. I just get going. I'm not going to make you suffer. Week 5, respiratory cardiac. A lot of good information on this cahoots, guys. A majority of upper respiratory infections are caused by what? Upper respiratory infection, URIs. What is it? All viruses. Remember, upper respiratory, they're viruses. Tylenol, Motrin, fluids, rest. That's the treatment. You walk into a 6-year-old child's room and you find them not breathing and does not wake up. What are you going to do? Again, this is why you took CPR, right? You start chest compressions immediately. Now, they used to say give 2 breaths and then chest. And what happened is many people weren't reviving them because they're not going to put their lips on a stranger, right? So today, we just say start chest compressions. There's enough oxygen left in the body to be fine. Multi. What are some signs and symptoms that smaller children may exhibit that has a respiratory infection? I know number one, any kid who stops eating and doesn't want to drink their apple juice, there's a problem. So it's fever, poor appetite, vomiting, abdominal pain, all of the above. And you need to get that fever down. Multi. What do you look for when assessing respiratory function? What's important? You want to see how fast are they breathing. Again, this is why you have all those vital signs that I gave you, right? What's normal? 40 to 60 is going to be your newborn. But, when you're talking about an 8-year-old is 30 too fast, you need to know that. If they're struggling breathing, their depth, ease of breathing, all of those things. Any retractions? What would you look for after a child has a tonsillectomy? So remember, you've taken those tonsils, you've cut them off and cauterized. You got these big scabs, literally, in the back of your throat. What's the thing that would concern you? And it's swallowing. If they're swallow, guess what? They're swallowing blood. And remember, if they're bleeding, it can be very dangerous. Like that little kid who had hemovolemic shock because she was bleeding like crazy. Multi. Nursing care for a child status post tonsillectomy include you're going to give medicines as ordered. You're going to, the older kid, the gum because it relieves the pressure, and an ice bag if they can. And if they want, give them some ice chips. They can have jellos, but don't give anything red because you don't know if it's blood, right? Makes sense. A multi. What would you suspect if a child has a dry, bothersome cough that keeps them awake at night? Remember, this is the one where, they need cough medicine. It's the most annoying of all of the upper respiratories, I think, because it's dry. It's not full of boogers. It's just this dry cough, 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 cough. It's either called bronchitis or tracheal bronchitis. Same thing. It's just giving you the medical term and then the shortened version. Another multi. What signs and symptoms would you see in a child with otitis media? Again, always, any infections, always no. Always, it's going to be a loss of appetite. Absolutely guaranteed. And it's always ear pain. And they're going to take their hand and go to the other side because this is the one that hurts. And when I see that, I want to cry with them. They do not always have a fever. Sometimes they have no fever. The monthly immunization for RSV is remember, this is given for those immunosuppressed, premature children that you really don't want them to get this because all it is mucus in the upper respiratory. It's called Synagis, palvizumab. You need to remember that. Hib is your hepatitis. Indocin is for your PDA. And Humira is for rheumatoid arthritis. All of the following are signs of early respiratory distress in children, except So if you had a kid who's in respiratory distress and all of a sudden they're like this, you better have a crash cart and a physician next to you because they're about, as we call, crash and burn. Absolutely. And it's bradycardia. Because as they have respiratory distress, they're tachypnic and they're tachycardic. And of course, restless. A 4-year-old's been taking meds for the asthma, but he's still wheezing. What information is important that you know? They've been taking their meds, but they're still wheezing. And this is a tricky question. But if you think about it, if they're taking their meds, are they taking it properly? How many kids can, at the same time? So did they use a spacer? So give them the med with a spacer, and it's probably going to work. I've seen it. An 8-month-old with croup exhibits what signs and symptoms of respiratory distress? Remember, croup is all inspiratory. And remember, asthma is all expiratory, okay? Those are the two things you must remember about respiratory. So, croup, inspiratory, they can't get air in, substernal retractions, and they're getting restless because they're getting hypoxic, and they're barking like a seal. Signs and symptoms of asthma include all except what? My husband went into status asthmaticus, really bad, and almost for 12 days straight. It was that severe, and I wouldn't let him intubated. And when you listen to him breathe his air out, there at the end with that's all you could hear in the lungs. It was such you could get air in and it's trapped. You can't get it out. So that is the big thing. It's a prolonged expiratory phase trying to get air out, okay? Signs and symptoms of congenital heart disease include all except congenital heart disease. Something's wrong with the heart. They're not going to be gaining weight. Why? They're probably unable to eat as much. They're tiring out easy. They're tachypnic, tachycardic. Very good. Weight gain is going to be decreased. They're going to be skinny. What should you not do to children diagnosed with croup and epiglottitis? Remember, croup, epiglottitis are an inflammation of the oropharyngeal area. It's already swollen up in there. And I could also add on tonsillectomy on that one. So you never look inside there because you may create more swelling, okay? You want parents to hold them, keep them calm, especially for an IV. And soft tissues are sometimes done to look at the swelling there. The epiglottis is what? We know it can cause epiglottitis, but what is the epiglottis? That's that thing that covers the trachea when you swallow, right? Very good. Leaf-like piece of cartilage. Yes, it is. Treatment for infectious mononucleosis. Remember, mononucleosis is an Epstein-Barr virus, kissing disease. And we're going to worry about that spleen blowing up. So it's a virus, no antibiotics. A virus, an antibiotic is going to do nothing but give them stomach pains, vomiting, and diarrhea. No contact sports is absolutely it. And we are going to be given maybe Tylenol, Motrin. Yes, we would. In fact, that would be an answer there. A multi. When doing an admission on an infant with a low-grade fever and loose cough, what information is important? You get this new kid, infant. What do you really need to know? You need to take care of this kid. You need to make sure that kid is safe, you're safe, and all the kids on the unit is safe, right? It really doesn't matter APGARs at birth, but it's what is the fevers, immunizations. I mean, is this pertussis going on or something? We want to know how dangerous. And of course, have they been given Tylenol? And if they're old enough, after 6 months old, have they got ibuprofen? You need to know that so you can continue. What is cystic fibrosis? Remember, cystic fibrosis is two components. On cystic fibrosis, you have to worry about the chest and worry about giving pancreatase for the intestines for food. What is the greatest risk for an infant having a cardiac catheterization? Remember, any kid that looks like they may have a congenital defect or even older, you're going to be having an echo and absolutely a cardiac cath so that you can make proper diagnosis. When they come back from that cardiac cath, what is your biggest concern? And that's bleeding, okay? They're going to have decreased pulses. That's normal. Cardiac dysrhythmias, no, and they rarely going to have any reaction to the dye. How is cystic fibrosis identified? Remember I told you you're going to lick them, right? No, you're not going to. You're going to do a sweat test. It's going to measure the salt. And so remember, with cystic fibrosis, this child's losing salt. Never, ever restrict their salt. A multi. What is included in the plan of care for a child with cystic fibrosis? So remember, it is that aggressive chest physiotherapy, keep those lungs open, those pancreatic enzymes, high protein diet helps and aids with healing and muscle. And I told you, high sodium diet, they're losing it like crazy out their skin. So never, ever a low sodium diet. What is a drug of choice for pharmacological closure of a PDA? You have a PDA that's open and you don't need it. You need to close it. What drug can I give? That's indomethacin. Indomethacin keeps it closed. Prostaglandin is what that hormone is that keeps it open, that the indomethacin says, nope, stop, I don't need you anymore, okay? Prostaglandin is open, indomethacin closed. What is not a feature of tetralogy of Fallot? Now, the tetralogy of Fallot with that pulmonary artery has 4 components to it because it has all right-sided of the heart. So looking at those answers, it's right side. So that pulmonary artery definitely is going to have something stenosis with it. It also by itself has that ventricle open. It sort of helps with some blood flow. But because when you can't get blood going up into the lungs, that right ventricle stretches. That's the other thing. And then the 4th thing is actually the aorta sort of pushes over. But your aortic stenosis is left side, has nothing to do with tetralogy of Fallot. Remember, tetralogy of Fallot is those tet spells, those blue spells. What medication would you hold for an infant that is vomiting? Vital signs are 98, 88, and 32. And that's your digoxin. Good job. Why would a child with tetralogy of Fallot not gain weight at the normal rate? Remember, tetralogy of Fallot are times where the body is not getting blood through the lungs and not getting oxygen. So yes, there are periods of cyanosis, but it's that inadequate oxygenation. That is the real answer. All are examples of cyanotic heart murmurs, except which one? So remember I told you about those septal defects, whether it's atrial or whether it's ventricular, they are getting all of the that can be. So ASD actually should be there. And remember, aortic stenosis is there's still blood going through the lungs. It's just getting very slowly going out to the body. Tetralogy, yes. And remember, tricuspid atresia is nothing that's going in. But an ASD, VSD, aortic, and PDA are all non-cyanotic. What is the most common cyanotic congenital heart defect? And that's the one you're tested on all the time. And that is your tetralogy. The rest of them, thank goodness they're not common. And PDA is not cyanotic. As I said, that is acyanotic. That gives oxygen. Nursing care following a cardiac catheterization. What are you going to do? Or what aren't you going to do, right? Number one, you're not going to raise the head that high because it could cause that scab to come off and bleed. You're going to leave that affected extremity alone because moving it, again, the clot, never out of bed for 24 hours. You are going to check that site for either hematoma or for bleeding. Yes. A multi. Nursing education for the cardiac catheterization include all except what? As in, which one of these aren't you gonna do? We're gonna teach a lot of stuff. We're not gonna ambulate and we're not gonna bend that extremity. And that pressure dressing will be there, and older kids are having a sandbag on it. They need to know. Which information is the most important when rheumatic fever is suspected? The rheumatic fever, we're worried about the pharyngitis, which could be strep because it is caused by strep. Signs of shock in children include all of the following, except what is shock? What do you see? Heart's not working right. And you're going to see hypotension, low blood pressure, elevated heart rate, decreased capillary refill, altered mental status, hypotension. Which of the following best describes the pathophysiology of Kawasaki disease? And those eyes get so red. The big thing is multi-system vasculitis, which may affect coronary arteries. Very good. A clinical manifestation of Kawasaki disease is, what would you see? So you see the blistered palms of the hands, soles of the feet, strawberry tongue, reddened eyes, and it's not that rash. That's more of the big patchy. It's more that fine papular type of rash, not that one, but it is a type of rash. What is the treatment for Kawasaki? Remember, Kawasaki is a virus. It's not antibiotics on this child at all. It is usually a month-long treatment, actually, and it's aspirin to prevent clots and to keep blood flowing, and the IVG to boost the immune system. Which of the following is the most common cause of shock in infants and children? Shock. What is it caused by? Kids. Usually infection. Septic shock is the most common of all of them, okay? Overwhelming sepsis, they can't handle it. What are the defects associated with tetralogy of Fallot? Mentioned it earlier. Let's see if you remembered. Remember, tetralogy is all right side of the heart. That's the one way that you need to think about it all the time. So remember, blood can't get up into the lungs through the pulmonary artery. It's blocked. So pulmonary artery stenosis, VSD, misplaced aorta, right ventricular hypertrophy, all right side. The rest have some left-sided stuff on it. A young child with tetralogy of Fallot may assume which position naturally when having a tet spell. Now, infants having a tet spell, we need to do something to pop open what's ever causing that pulmonary artery to be closed. So we do need a chest. There are older children that do have tetralogy. And what they do is they just squat naturally. And what that does, it changes the pressure between the abdominal cavity and the chest cavity, and it will pop it open. So knee chest on infants or older kids will squat. And older kids do have tetralogy. Transposition of the great arteries is what? What are the great arteries? And transposition means what? They're switched, right? So what switched? And that's the pulmonary artery and the aorta. They're switched. And again, the PDA keeps that child oxygenated. Which of the following is not an intervention indicated for transmission of great arteries? Now, this is a huge, huge diagnosis. This requires surgery, and it requires, the best of everything we can to keep this child alive until we get them to surgery. And I'll tell you, the name of it is called an arterial switch operation. So we need oxygenation, as I said. So we need that prostaglandins on to keep that PDA open. Sometimes we have to put a hole between the atrium, where the foraminal valley is, right? We need to keep it open. Oral vasodilators is weak. It does nothing. It has nothing to do with what can help them. It's all done IV. It's all done by procedures, and then it's done by the surgery. Multi. Why is prostaglandins given to the child with transposition of the great arteries? Said it about 3 times now. Do you remember? What does prostaglandins do? This little infant here has a pacemaker in. So prostaglandins, oxygenation maintains cardiac output, has nothing to do with infection, okay? Prostaglandins, all it does, it keeps the PDA open. That makes oxygenation and helps with cardiac output. That's it. What is the purpose of giving indomethacin to a neonate with a patent ductus arteriosus? So remember, a patent ductus arteriosus is kept open with prostaglandins. If we give indomethacin to a child with a PDA, what does it do? It stops prostaglandins from working and it will close. Very good. You'll see that pulse pressure come down and you'll see that washer machine murmur go away. Where is that patent ductus arteriosus? We mentioned it at least 5 or 6 times already. We know it has something to do with oxygen, right? PDA keeps oxygenation to a child who needs it. So it connects the aorta to the pulmonary artery. So it gives oxygen to the body through the aorta. That's how you remember that. The heart defect allows blood to pass from the left ventricle to the right ventricle is called what? Right ventricle to the left ventricle. What do you have? What's that defect? That the blood can just go there. It's not supposed to, right? There should be something to stop it. It's called a VSD, just like if it was left atrium to the right atrium, same thing, a atrial septal defect. A multi. What is a sign of ditch toxicity in infants? And the key word is in infants. You'll see the vomiting and you'll see their heart rate low. In adults, you see the yellow spots, maybe, okay? That's why I emphasize infants. Vomiting, heart rate, and you'll see like gagging with nausea. You will see it. What is congestive heart failure? It's just a weak heart and it can't squeeze all the blood out and it goes backwards and fills up the lungs. Basic. Left-sided congestive heart failure causes what? Blood can't get out of the left side of the heart. What happens? Where does the blood go? If it can't get out, it goes backwards. Where does it fill up? And that's shortness of breath, coughing, fluid in the lungs, because that's where the blood goes. It's all filling up into the lungs, all respiratory things you'll see. After a heart transplant, what is the leading reason children die? The number one reason. Rejection. It's not infection, it's rejection. Remember that one. Multi. Signs and symptoms of rheumatic fever include and remember, rheumatic fever is due to a strep infection. Everything can be turned around with antibiotics, long-term antibiotics. The only thing we can't would be mitral valve if it gets to there. But everything can be taken care of. Respiratory, polyarthritis, chorea, and they're like little nodules that you will see. And all of that can happen in 3-4 weeks if you don't treat strep. Multi. A child's about to have a chest tube removed. What should you do? I already told you about chest tubes. Always explain it to them on their level. Always be honest. It's going to hurt. And you're going to put that child actually in a sitting position. If you lay them down, it hurts worse. And always medicate them for pain. Vital signs, medicate, explain it, and tell them it's going to hurt for a little bit. Be honest. A child just had abdominal surgery cannot cough well enough to expectorate secretions. What is your priority? You need this kid to cough. If he's not coughing, you're going to have, atelectasis of the lungs, and you're going to have more problems. So what are you going to do? You're going to medicate him for pain. Number one, he can't cough well enough. He's probably in pain, just had surgery. Then you can move him, get him out of bed, do incentive spirometry after pain medicine. Don't forget pain medicine. An infant of 3 months has a fever of 103.6. What would you medicate the infant with? You cannot medicate a child with anything for an infant that's less than 6 months, but acetaminophen. At 6 months old, you can start ibuprofen, Motrin, okay? So only Tylenol for the first 6 months. A newborn infant is assessed. The nurse finds the very weak lower extremities. What should she assess next? What did I tell you about that low blood flow, low pulses in those lower extremities? What do you need to do now? You're going to be diagnosing before we do echoes or we do anything. And we're going to do a 4 extremity blood pressure because low flow down to lower extremities are lower blood pressures. And then the uppers have more blood flow, they're going to be higher. And it's really going to tell you what it is. A multi. A critically ill child is on complete bed rest. What can a nurse do to prevent complications? Children can get really sick and they can be, in bed for long periods of time. And, we know what to do with adults. We've been, always taught about that. Adults, you do this, that, and the other. Guess what? You're going to do the same thing that you do for adults. They're going to use that instead of spirometry. You're going to keep them dry with either blankets or chucks or whatever that you need. And pillows and blankets are going to be used. Now, elevate the head of the bed only if they're allowed to. So that's one. Sometimes you can, sometimes you can't, depending on what's going on with the kid. How can oxygen be delivered that is the easiest, tolerated, and accurately monitored for infants? It's a little bit off of last week's information that I'm bringing back. And that's the oxy hood, because even the nasal cannula, we tape it to hold it there, and they're pulling it off and ripping it off. So that is the best, and it's the most accurate. They can look around, suck their fingers. A multi. What procedure are used to keep the lungs open with a child with cystic fibrosis? Remember, cystic fibrosis is making sure that we keep the lungs open and that we are taking care of the nutritional deficiency with the pancreatase and monitoring their nutrition with, growth, height, and weight, making sure they're okay. Deep breathe, cough, exercise, chest PT, everything on a regular basis. Not ambulating PRN, ambulating every 4 hours, okay? So that's why that one not right. a multi. Children with cystic fibrosis require pancreatic enzymes with meals. What teaching should be done? Take it right before meals or snacks. Sprinkle it on a capsule. If it's powder, make sure they rinse. And don't forget to make the dose bigger as they grow older. Something we forget in peds actually quite a bit. What is a cardiac defect when there's no valve between the right atrium and right ventricle? So the answer is, what valve is between the right atrium and the right ventricle? That's why I say you need to know anatomy. And that's a tricuspid atresis, tricuspid valve. And last question. When an infant is breathing fast, tires easily, and needs rest periods during feeding, what should you assess?
I kicked my toe.
You kicked your toe. So when you're seeing that really struggling, tiring out, you need to listen to their breath sounds. Are they filling up with fluids? That's the most important thing. Good job, guys. Here we go. Number 3, Jay. Good job, Jay. Whoop, whoop, whoop. Number 2, John. And number 1, doop, 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 doop. Denai. Good job, Denai. Number 4, Veronica and KS. All right, guys, great class. I know it's a lot of information, so thank you for your patience. I will be sending this out as soon as I have the recording. And I actually made pretty good time tonight for a really lot of information. Anybody who needs any help with cardiac, let me know. Okay, I will explain it to you. I do have other recordings. If you want to listen to another way I explain it, pick another one from another semester. Okay. Good luck, guys. Thank you. Next week is all of the reviews for exam 2. So I'm doing mine, what is it, Thursday, I think. I don't know. I'll be sending it out by Friday. I already have the study guide ready to go. Okay.
Professor,
you,
what
guys.
we learned today is going to be on the exam.
On the what?
What we learned today, is it going to be on the exam?
Absolutely. Many of the concepts, prostaglandin, synergist, congestive heart failure, tetralogy, poor growth, oxygenation. Absolutely. It is a really jam-packed one. I did cover a lot of those concepts on the COOTS, so I believe I've taught you. And that's little Christian. He wanted to say hello. That's my grandson.
Hello.
No, they all live in Miami. Say hello. You guys have a great night. Thank you so much.
Thank you, Professor.
Thank
Bye-bye.
you, Professor.
Thank you. Good night.
Thank you, Professor.
Thank you.